Hello, and welcome to this weekly pelvic perineal literature watch for May 22nd, 2026, presented by Erwan Lerumeur, physiotherapist in Paris. This is for information only, not individualized medical advice. This week, the watch retrieved 66 articles. The selection is not as dense as in some previous weeks, but it includes several papers that are directly useful for clinical reasoning, pelvic pain, endometriosis, diagnostic pitfalls, postoperative functional outcomes, and symptom measurement. The editorial line today is pelvic pain, endometriosis, and diagnostic pitfalls. We will look at what symptoms can and cannot predict, what imaging may add, and what should not be missed when anorectal pain or bleeding looks like something else. Then we will move to practical papers on urinary retention, continence, anal incontinence, and outcome measures. First section, the must-read papers, when symptoms are not enough. The first must-read paper is by Reiser et al., published in Fertility and Sterility under the title Predicting Superficial Peritoneal Endometriosis in Symptomatic Women with Negative Examination and Imaging. It is probably the most useful paper of the week for pelvic pain reasoning. The authors address a very common scenario: symptomatic women with suspected endometriosis, but negative clinical examination and negative imaging. The difficult question is whether symptoms and quality of life questionnaires can predict who will ultimately have superficial peritoneal endometriosis at surgery. This was a multi-center nested case control study conducted in 18 certified endometriosis centers in Austria, Germany, and Switzerland. From an initial cohort of 845 women undergoing first-time surgery for suspected endometriosis, the authors selected 229 women with either isolated superficial peritoneal endometriosis or no endometriosis. In this group, 121 women, or 53%, had isolated superficial peritoneal endometriosis, and 108 had no endometriosis. A separate external validation cohort of 268 women was then analyzed. Two factors were associated with superficial peritoneal endometriosis: severe dysmenorrhea and symptom duration longer than 3 years. The odds ratio was 2.01 for severe dysmenorrhea and 2.40 for symptoms lasting more than 3 years. But the central finding is that the predictive score did not perform well. The 5-item score reached an AUC of 0.64 in the development cohort and then dropped to 0.49 in the external validation cohort. In other words, once tested outside the population where it was created, the score had almost no predictive value, and this is uncomfortable but clinically useful. It means that a highly suggestive symptom profile is not the same as a diagnosis. Dysmenorrhea, dyspareunia, dyschezia, fatigue, impaired quality of life, and altered sexual function may be present in endometriosis, but also in other chronic pelvic pain conditions, bowel disorders, bladder pain syndrome, pelvic floor myofascial pain, musculoskeletal disorders, scar-related pain, or mixed mechanisms. The paper does not say that symptoms should be dismissed. It says that symptoms alone cannot reliably identify superficial peritoneal endometriosis when examination and imaging are negative. For clinical practice, this means being clear during counseling. Laparoscopy may find lesions, but it may also be negative. And before attributing every unexplained pelvic pain presentation to invisible endometriosis, the differential diagnosis should remain open: pelvic floor, bladder, bowel, nervous system, musculoskeletal context, scars, and central sensitization. The second must-read is by Wu et al. In the Chinese Medical Journal, estimating minimal, moderate, and marked clinically important differences for patient-reported outcome measure in randomized controlled trial. The paper is methodological, but its clinical implications are direct. The authors use data from a multi-center randomized controlled trial of acupuncture versus sham acupuncture in 440 men with chronic prostatitis and chronic pelvic pain syndrome, using the NIH-CPSI as the core patient-reported outcome. The strength of the paper is that it separates two concepts that are often confused. First, the within-group change, what a patient may perceive as minimal, moderate, or marked improvement. Second, the between-group difference, the size of the treatment effect compared with a control or placebo group. The proposed thresholds are practical. For the total NIH-CPSI score, within-group clinically important differences were 4.6 points for minimal improvement, 6.0 points for moderate improvement, and 7.3 points for marked improvement. The corresponding between-group differences were much smaller: 1.4 points, 2.7 points, and 4.1 points. For pelvic pain clinicians and researchers, this distinction matters. A patient may improve substantially over time, but not all of that improvement can automatically be attributed to the intervention. Conversely, a between-group effect may look modest and still represent a meaningful advantage at trial level. In chronic pelvic pain, this helps avoid two errors: overclaiming from before and after changes and dismissing potentially useful interventions because average treatment effects look small. Second section, thematic focus, endometriosis, pelvic pain, and diagnostic complexity. After Reiser et al., the paper by Yang et al., published in Archives of Gynecology and Obstetrics, gives a useful counterpoint from the imaging side. The title is A Nomogram Integrating a Novel Uterine Isthmus Ratio, Sonographic Signs, and Clinical Symptoms for Predicting Posterior Deep Endometriosis. And this time, the target is not superficial peritoneal disease with negative imaging. The target is posterior deep endometriosis. The study is retrospective and includes 362 patients with endometriosis who underwent transvaginal ultrasound and surgery between 2021 and 2024. Among them, 153 had posterior deep endometriosis and 209 did not. The authors built a nomogram combining ultrasound findings, a new anterior-posterior uterine isthmus thickness ratio, and clinical symptoms. 4 key predictors were selected: APTUIR, posterior uterine wall sliding line, endometrial polyps, and menstrual bowel dysfunction. The performance was strong: AUC 0.933, sensitivity 85%, specificity 88%, and overall accuracy 86.7%. The study remains retrospective and the validation is internal, so it should not be treated as a final clinical rule, but it highlights an important contrast. For superficial peritoneal endometriosis with negative imaging, symptoms perform poorly. For posterior deep endometriosis, structured ultrasound combined with selected symptoms may stratify risk much more effectively. The issue is not whether symptoms matter or do not matter. The issue is which phenotype is being investigated with which tools and in what clinical contexts. Still within endometriosis, Raimondo et al. In Facts, Views, and Vision in ObGyn present robotic ureteral reimplantation for endometriosis, the Lich-Gregoir technique. This is a technical surgical paper, but it carries an important message for all pelvic health professionals. Urinary tract endometriosis affects fewer than 6% of patients with endometriosis, and ureteral involvement is the second most common urinary site, reported in roughly 9 to 23% of urinary tract endometriosis cases. It may be asymptomatic and may silently compromise renal function. The case presented involves a 47-year-old nulliparous woman with dysuria, deep dyspareunia, and dyschezia. The procedure combines excision of parametrial and vaginal endometriosis with robot-assisted extravesical ureteral reimplantation using the Lich-Gregoir technique. For non-surgical clinicians, the point is not to learn the surgical steps. The point is to remember that some pelvic pain presentations with urinary or bowel symptoms may reflect severe anatomical disease. Dysuria, deep dyspareunia, dyschezia, lateralized pain, or known deep infiltrating endometriosis should not be too quickly explained by pelvic floor overactivity alone. Pelvic floor dysfunction may coexist, but it may not be the primary driver. Another frequent clinical issue is the caesarean scar niche. Perini et al. In Minerva Obstetrics and Gynecology published symptom relief through hysteroscopic treatment in patients with isthmocele, a retrospective single-center study. Isthmocele is a myometrial defect at the site of a previous uterine scar. It may present with intermenstrual bleeding, dysmenorrhea, chronic pelvic pain, and secondary infertility. This is a small study. 32 patients, mean age 44 years, with a median follow-up of 54 months after outpatient hysteroscopic isthmoplasty performed without anesthesia, but the results are clinically relevant. After treatment, 56.3% of women reported complete resolution of intermenstrual bleeding. The remaining patients reported decreased bleeding intensity from 7.14 to 4.07 on a numerical rating scale. Dysmenorrhea decreased from 71.9% to 46.9%. Non-bloody vaginal discharge decreased from 53.1% to 18.7%. No severe complications were reported. This is not definitive evidence. It is retrospective, single center, and small, but it reinforces a practical point. In women with a history of cesarean section, pelvic pain, dysmenorrhea, intermenstrual bleeding, or secondary infertility, isthmocele should be considered. Pelvic floor treatment, scar work, and pain modulation may be useful, but they should not replace targeted gynecological assessment when the pattern fits. The paper by Harvey et al. In the Journal of Clinical Investigation provides provides a mechanistic perspective. Repeatedly occurring retrograde menstruation intensifies central sensitization driven by neuroinflammation in endometriosis models. It is a preclinical study using mouse models and data from rhesus macaques with spontaneous endometriosis, repeated retrograde menstruation, increased lesion burden, hypersensitivity, persistent glial activation across brain and spinal regions, and persistent expression of TRPV1, substance P, and CGRP in dorsal root ganglia. It also altered peritoneal macrophage populations and maintained elevated cytokine levels. This paper does not validate a specific treatment in humans, but it gives biological support to a common clinical observation: endometriosis-associated pain may extend beyond visible lesions. The proposed pathway links repeated peripheral inflammatory stimulation, neuroinflammation, and central sensitization. Clinically, that means lesion-based and nervous system-based explanations should not be opposed. Both may be true at the same time. The last paper in this pelvic pain section deliberately steps outside endometriosis. Cadillac et al. In BMC Infectious Diseases report diagnostic delays and persistent symptoms in lymphogranuloma venereum among men who have sex with men in Poland. This is a small single-center case series of 7 symptomatic men who have sex with men diagnosed with rectal lymphogranuloma venereum. 5 were living with HIV, rectal bleeding, rectal pain, and mucopurulent discharge were each present in 71% of cases. The median time from symptom onset to diagnosis was 6 months, and patients consulted a median of 3 physicians before diagnosis. 5 underwent colonoscopy with findings initially suggesting inflammatory bowel disease or malignancy. After doxycycline treatment, persistent anorectal symptoms were reported in patients with diagnostic delays of 6 months or more despite microbiological cure. This is a useful differential diagnosis reminder. Rectal pain, bleeding, mucus, urgency, or inflammatory endoscopic findings are not always inflammatory bowel disease, fissure, cancer, or functional anorectal pain. Depending on the context, sexually transmitted proctitis, including LGV, should remain on the list. Third section, for practice: retention, continence measurement, and patient counseling. Moving away from the main pelvic pain focus, several practical papers are worth noting. Alvandepour et al. In Scientific Reports report a double-blind placebo-controlled randomized trial effect of intrasphincteric botulinum toxin on postoperative urinary retention following stapled hemorrhoidopexy. The study included 68 adults undergoing stapled hemorrhoidopexy for grade 3 or 4 hemorrhoids. Participants received either 50 units of botulinum toxin A injected into the internal anal sphincter intraoperatively or placebo. Postoperative urinary retention was clearly defined: failure to void within 6 hours, bladder volume above 400 milliliters on ultrasound, and need for catheterization. Overall retention occurred in 30 patients, or 44.1%, but the rate was 20.6% in the botulinum toxin group versus 67.6% in the placebo group. After adjustment for age and sex, placebo treatment was independently associated with higher odds of retention, with an adjusted odds ratio of 8.87. There were no significant differences in postoperative bleeding or gas incontinence, and the key limitation is that retention was a secondary analysis from a trial originally designed around postoperative pain outcomes. Still, the signal is strong. It suggests that after anorectal surgery, anal sphincter tone and local pain may interact with voiding. This is a useful example of functional overlap between anorectal pain, autonomic responses, pelvic floor tone, and bladder emptying. In pelvic organ prolapse surgery, Saraluk et al. In International Urogynecology Journal present multimodal prediction model for postoperative voiding dysfunction after pelvic organ prolapse surgery. The study includes 283 women undergoing surgery for advanced prolapse. At 6 months, postoperative voiding dysfunction occurred in 56 women, or 19.8%. The model performance improves stepwise. Clinical variables alone give an AUC of 0.68. Adding uroflowmetry raises it to 0.72. Adding urodynamic parameters raises it to 0.78. The combined model reaches an AUC of 0.82 with stable bootstrap validation and good calibration. This does not mean that every patient must undergo full urodynamics before prolapse surgery. It means that postoperative voiding dysfunction is not a random event. Risk can be estimated more accurately when clinical, flow, and physiological data are combined. This can improve preoperative counseling and postoperative planning. And in male pelvic health, Negri et al. Externally validate a continence prediction model after prostatectomy using MRI-derived membranous urethral length. The cohort includes 500 patients with preoperative MRI and validated postoperative continence assessment. 1 year after prostatectomy, strict continence, defined as 0 pads per 24 hours, was achieved by 312 patients, or 62%. A broader definition, 0 to 1 pad per 24 hours, was achieved by 450 patients, or 90%. The model was not useful for predicting strict 0 pad continence, see statistic 0.64, poor calibration, and no net benefit on decision curve analysis, but it was more useful for predicting 0 to 1 pad continence with a C statistic of 0.69, moderate calibration, and net benefit across clinically relevant thresholds. This is a good example of why outcome definitions matter. Predicting no pad at all is not the same as predicting a socially acceptable continence outcome. For patient counseling before prostatectomy, this distinction is not cosmetic, it changes expectations. Measurement also comes up in Amorim et al. In International Urogynecology Journal with instruments for the assessment of fecal and anal incontinence, a scoping review. The review includes 52 studies describing 52 assessment instruments. Most are self-administered questionnaires, 34 out of 52, or 65.4%, and most focus on quality of life. Only a minority have complete psychometric validation, formal cross-cultural adaptation, or objective anorectal motor and sensory assessment components. For teams managing fecal or anal incontinence, the message is practical. Many tools exist, but they do not measure the same thing. Frequency, severity, bother, social restriction, quality of life, and anorectal function are related but distinct outcomes. Choosing a score by habit can make follow-up and research interpretation less precise. Zhao et al. In the Journal of Patient-Reported Outcomes evaluate quality of life instruments in pediatric disorders of gut-brain interaction. 14 studies and 9 instruments are assessed using COSMIN methodology. The instruments include generic tools such as PEDS-QL 4.0 and EQ5-DY, and disease-specific tools such as the PEDS-QL gastrointestinal symptoms scales and the defecation disorder list. The authors conclude that PEDS-QL 4.0 has the strongest support for broad health status assessment, while disease-specific tools better capture gastrointestinal impacts. Evidence remains incomplete for several measurement properties, especially structural validity and responsiveness. Even though this is pediatric and gastrointestinal, it is relevant to pelvic perineal practice. If we want to measure a functional disorder, we need tools that match the clinical question. General quality of life is not always sensitive enough to track bowel dysfunction, pelvic pain, or treatment response. A final practical paper comes from Zorlu and Uslu in Intensive and Critical Care Nursing, Effect of Urinary Catheter Securement Band on Meatal Pressure Injury in Male Intensive Care Patients. This randomized trial includes 248 adult male ICU patients. The intervention group received a catheter securement band plus standard care. The control group received standard care alone. Meatal pressure injury occurred in 6.5% of the intervention group versus 16.1% of controls. Protective factors included catheter securement, silicone catheters, higher Braden scores, and shorter ICU stay. Advanced age increased risk. This is basic prevention, but clinically important. A poorly stabilized urinary catheter in a sedated, fragile, or dematous patient can create avoidable urethral injury. Catheter management is part of pelvic perineal safety. Last section briefs 3 signals worth keeping. First, Nilsson et al. In Acta Obstetricia et Gynecologica Scandinavica analyzed the long-term effect of delivery mode and obstetric anal sphincter injury on anal continence. The study links registry data and questionnaire responses from 13,480 women aged 40 to 64. 20 years after first birth, fecal incontinence was highest after 2 vaginal deliveries, 14.2%, and lowest after 2 cesarean deliveries, 10.2%. Among women with 2 vaginal deliveries, fecal incontinence was almost twice as frequent after obstetric anal sphincter injury, 23.3% versus 13.7%. The clinical point is clear: OASI is not only an immediate postpartum issue. Second, Girit Ozdin et al. In International Urogynecology Journal compare yoga-based and Pilates-based respiratory training in 46 women with stress or mixed urinary incontinence. Both groups completed a 6-week home program, 5 days per week, twice daily, 20 minutes per session, with physiotherapist supervision at baseline and follow-up. Both improved ICI, QSF, quality of life, and pelvic floor contraction activity. The yoga-based group showed greater improvement in quality of life and resting pelvic floor SEMG activity. The sample is small, but the study supports the idea that structured respiratory training may be a useful supervised home-based component in selected patients. Third, Vaghiri et al. In Techniques in Coloproctology publish a systematic review and meta-analysis on whether to close or leave open the rectal wall defect after full-thickness transanal excision. 6 comparative studies are included. Closure is associated with less rectal bleeding, odds ratio 0.57, and fewer readmissions, odds ratio 0.34, with a slightly longer operative time. Both strategies are feasible, but closure may reduce early postoperative events. Conclusion. This week's central message is that pelvic pain does not fit neatly into a single diagnostic box. Reiser et al. Show that when examination and imaging are negative, symptoms alone poorly predict superficial peritoneal endometriosis. Young et al. Show that for posterior deep endometriosis, structured ultrasound combined with selected clinical features may perform much better. Between these two situations lies the real complexity of pelvic pain. Visible lesions, urinary involvement, bowel involvement, scars, infection, pelvic floor dysfunction, and central sensitization may all contribute. The practical papers add a second message: better measurement supports better decisions. NIHC-PSI thresholds, anal incontinence instruments, pediatric gut-brain quality of life tools, MRI-based continence models, and postoperative voiding prediction models all point in the same direction. A score is useful only when it answers a clear clinical question. Thank you for listening, and always check the full papers and current guidelines before changing practice. References are available in the description, and see you next week for another edition.